Hello, this is Daniel Wolfson from the ABIM Foundation, and today I'm joined by Jill Yegian. She is the Senior Vice President of Programs and Policy with the Integrated Healthcare Association, IHA. So we're here to talk about your grant, Jill, from the ABIM Foundation and the Robert Wood Johnson Foundation. But before we begin that, could you explain the mission and functions of IHA?
Absolutely, Daniel. I'd be glad to. At IHA, we're really focused on creating credible, actionable information that enables sustainable improvement in California's healthcare systems. And we do that through multi-stakeholder, cross-sector collaboration and innovation. So this Choosing Wisely grant is a terrific opportunity for us to do work that is directly in line with our mission.
So how did you get involved in Choosing Wisely? How did that, again, fit in with your mission?
You know, we have a tremendous diverse board of close to 50 members, and it was a request from one of our members to submit a proposal on behalf of several of our member organizations that led to the grant.
So could you explain your initiative, what your targets are, what your strategies for achieving your goals, both on the health system side externally, but also with your internal audience, consumers, patients, and the larger community?
Absolutely. We have a tremendous team. It's really a pleasure to work with them. It is anchored by two large delivery systems in the state, one that's more focused on the north, Sutter Health, and a second one that is in San Diego, Sharp Rees Steely Medical Group. And these are both strong, really leading systems in the state. Both of them, as you know, have one of their key target areas as antibiotic reduction of antibiotic overuse. And then they chose different target areas for the other two focus. Both of them are focused on imaging, and Sutter is focused on headache, and Sharp Rees Steely focused on low back pain. And then they both have a measure that is related to inpatient, but they're different. On the Sutter side, their focus is on not doing the repetitive lab testing on an inpatient basis when it's not necessary. And at Sharp Rees Steely, it's on preoperative stress testing for non-cardiac surgery. And they're really pursuing a number of similar interventions that really go towards provider behavior change with support on the consumer member side. And in particular, Sutter has a very well-developed process across its system called variation reduction that's anchored by small group meetings with clinicians to really get them engaged in the change process, and then to follow up with tailored information on their own data at the individual physician level. Sharp has gone down a similar path, less focused on the face-to-face meetings, which really are core to the Sutter approach, but definitely anchored by delivery of provider education materials, and then also the follow-up with the detailed data at the individual physician level that provides feedback so that docs know where they are and how much they need to move to come in line.
So what do those conversations look like? That reminds me of Howard Beckman's work, where he shows variation and then sits down with an important conversation about that data and tries to have conversations about what is causing the variation, what is true variation, and what is just different risks. What do those conversations look like?
You know, I think there are two key elements to it. And of course, our delivery system folks could provide that perspective on the ground. But in my conversations with them, what I've taken away is that there are a few key elements. One is that you really need to engage the providers. The physicians cannot just be, they'll tune you out if you show up sort of finger wagging and saying, this is what you need to do. It begins with, look, here's the data. And that's the second piece, is really being able to present information that's both comprehensive, so it shows their peers and has some benchmarks and available evidence on best practices, and then also shows exactly where they individually fit in that bigger picture. And when you have that breadth of data and you have the evidence and the clinical guidelines on best practices, and you can show them how they look relative to their peers, that's really what drives the behavior change. And those things go hand in hand, the openness and the receptivity to having the conversation and changing, and the data that helps provide that direction. And then the follow-up. So what is it that they're trying to implement at the practice level? And then what are the results of that they can see in the follow-up data in terms of, for example, the number of antibiotic prescriptions that were one of the target areas, or the number of pre-op stress tests that were inappropriate and such.
And through those conversations, they can develop their own strategies of solving the problem. They have the kind of the autonomy to say, okay, I'm an outlier. Now this is what I'm going to do from a systems point of view, education point of view.
Absolutely. And there are a number of additional components that can really be helpful depending on how much infrastructure and how much is available in terms of bandwidth and resources. So for example, in the grant, it is amazing to have the partnership and the resources in from the consumer reports folks. And both Sutter and Sharp are very interested in taking advantage of the opportunity to build out a microsite that will allow, for example, a patient portal. So ideally then, when you have a patient that goes to book an appointment, say the appointment indicates that they have an interest in a low back pain image, or there's something that triggers them to go and be directed to the Consumer Reports resources. Those are also extremely helpful to have while they're consumer facing in the hands of the provider at the point of service. So while the core of the intervention to change the provider behavior may be with the doc or the clinical team, that wraparound of the very appropriate, well-designed, well-worded consumer education that can be used both by the system on a website or in some form of the patient intake, as well as in the clinical setting with the provider, is really helpful. So being able, instead of giving a patient a referral for an image, the physician can give the patient the Consumer Reports handout on low back pain imaging and when it's appropriate and when it's not.
What are some other partnerships that you have? We talked about Sutter and we talked about Sharp, we talked about Consumer Reports. Are there other partnerships you have to reach the general public?
Yes, although the general public is not at the top of our list. In California, as you know, is a state of, 35 plus million people. And so we generally have a strategy of reaching the influencers, so the docs and the systems and the plans and purchasers and other stakeholders in the system that can then do that hard work of change with their own members, patients, constituents. So for example, one of our partners is Blue Shield of California, and they have millions of members in the state. And so much more effective than IHA trying to directly reach the general public, Blue Shield can really have a direct line to its members and has actually actively adopted the Choosing Wisely materials, in particular the 5 questions approach, and is really advocating that and has adopted that in member communications.
That's great. So what do you see as some of the barriers for success, both in cultural change and both in achieving the goals of 20% reduction in use over a 3-year period?
You know, there are quite a few, and I will return to that in just a second, Daniel. I want to just touch on the other core members of our team, because they are terrific contributors as well, and really essential to rounding out our project. One of them is the Center for Healthcare Decisions, and that is a terrific small nonprofit that takes on really pulling in the citizen perspective, in particular on issues related to resource use. And here what they are doing is a project that is separately funded but very well integrated with our work, called Doing What Works. And what they do is what's called deliberative discussions, where they have an intensive 4+ hour session with 10 to 12 individuals. In our project, they're targeting Medicaid beneficiaries or Covered California members, which is California's exchange. And they explore in detail and engage those individuals in problem solving, as opposed to a focus group setting where you're just getting their opinion about something. In this setting, you present a case, and in this situation, there's a case related to antibiotic overuse, and there's also a case related to low back imaging. And then the people around the table really engage with the facilitator in solving that problem. So how should overuse be solved in this particular target area? And the objective is to then pull those results back in at a higher level for the stakeholders, purchasers, plans, to get a much more granular understanding of the consumer and the beneficiary view of overuse and how it should be addressed.
I've heard about that. That seems like a fascinating way to really get at the hearts and minds and beliefs of your audience.
I'm really excited about it, because it won't work if the effort to reduce overuse is seen as a takeaway and punitive from the consumer perspective, just as choosing wisely is such a leading light in the policy environment, because it's physician leadership and physician behavior change. The consumers need to be engaged and not told or taken away from. So this is a way to really understand their perspective and what will work in moving their behavior, which, as we know, contributes tremendously to the overuse problem, generally without them having really any understanding or realization that that's what's happening. So for example, seeking antibiotics or seeking imaging when it won't help. Our last partner, but by no means least, is the California chapter of the American College of Physicians, which, as you know, is very active as a partner with Choosing Wisely at the national level. And they have a tremendous network of physicians in the state of California, and have really been very helpful as a partner to us in raising awareness among the providers and the individual physicians across the state, and really getting out the word on Choosing Wisely and the way that it can be leveraged in practice to support physicians.
You really have some stellar partners. That is very impressive.
We do, and I can't help mentioning just in brief, and I think it may go to your question about the challenges and the barriers and how to overcome them. And that is that all of our partners are engaged in a broader effort, which we are calling the Statewide Work Group on Reducing Overuse. And this is a group that's co-chaired by the Exchange, Covered California, CalPERS, which is our public employees system in California, and the Department of Healthcare Services, which purchases and arranges coverage for California's Medicaid beneficiaries. And so collectively, they have about 15 million members among them. And all of our grantees have become involved in that effort, all of the partners on our team, as is the other California grantee in the cohort, the UCLA and LA County grantee. They're involved as well. And that group has focused on 3 large areas initially, and one of them is reducing cesarean section when it is not indicated. A second one is on imaging for low back pain without red flags, and the third is opioid dependence. And so when we think about what the challenges and barriers are to really creating a culture that moves us away from overuse and making it okay to say no when the harm outweighs the benefit or when it just isn't indicated. I think that kind of a leadership group has the potential over time to really set a vision and a direction and create an expectation at the highest level of purchasers that can trickle down to the plans, the provider systems, all the way down to the members and the patients, that we have higher expectations for our system that really go to patient benefit and reducing unnecessary care.
Well, you have a very competitive marketplace, and the competition causes the bar to get higher and higher.
It does.
So what do you hope to achieve by the end of the 3-year period, Jill?
Well,
What's your
Daniel,
measures of success?
well, we clearly are going to be working very hard at hitting our 20% targets for reduction among collectively there are 5 measures, the antibiotic shared measure, and then the other 4, 2 each from the 2 systems. So that's a given that we'll be striving hard to hit those targets. More broadly, we're really looking to create a shift in the culture, to raise the awareness about choosing wisely, to support physicians in their leadership efforts, to make it okay to say no when the care will not produce benefit, and hopefully to work with consumers and with patients to shift their expectations as well, so that both the physicians and the patients can be working together to a more effective system.
Well, you know, we have chosen wisely in selecting IHA to be a grantee. You have assembled an impressive partnership. Your organization has shown leadership through decades of work and quality and reporting and transparency. So good luck to you, Jill, and it's great to talk to you today. And for the audience, if you want to learn more about Choosing Wisely, go to www.choosingwisely.org, go to resources, and go to updates on the field, and these interviews will be posted on that resource section. Have a good day, and thank you again, Jill.
Thank you, Daniel.